Yeah, excellent. You answered it right. So this is a 10-year-old boy who have increased bronchoalveolar marking and several parallel linear opacities. Those that's bronchiectasis happen due to recurrent lung infections. So he's having multiple productive cough and yellow green, and he's adopted, so we don't know his family history. So the best bet is to do, and there's scattered bilateral bronchi and wheezing. So the best thing to do right here is a sweat chloride test. Excellent. So this is a cystic fibrosis case. Adenosine deaminase deficiency, we do it when there's a SCID, which is severe combined immunodeficiency. They have bacterial and viral infection, like you said. Excellent. They have viral like HSV, CMV, EBV, and bacterial and fungal like pneumocystis, candida. Those are types. Dihydrorhodamine oxidation test, we do it for chronic granulomatous disease, CGD. Let's call it, okay? CGD, they have recurrent infections with catalase positive organisms, and they have severe fungal and bacterial pneumonia and skin infections. Serum immunoglobulin, usually in a 30-year-old female who have recurrent sinopulmonary infections and diarrhea, recurrent diarrhea, and lung infections or sinus infections. Okay, that's we do quantitative immunoglobulin. Serum HIV, it's unlikely to be in this case who have a bronchiectasis recurrent pulmonary infections. So sweat
Right.
chloride is more common. So this cystic fibrosis, how do we manage cystic fibrosis? How do we test for it? We do first sweat chloride, and then we do genetic testing, and then we do something they call a potential difference. Okay, and they measure the action potential in the nasal and the nose. And then the management, you do nutritional support, airway clearance, and antibiotic coverage for Staph aureus and Pseudomonas aeruginosa. Period.